We are now live on YouTube.
Good morning, afternoon, or evening, everyone. Welcome to the 2020 IFMBE Clinical Engineering Division Competency Webinar Series. The topic in this episode will be quality and safety, in particular, improving health technology quality and safety for patients and medical staff. We remind you that we have more activities to share. In June 10, we have a meeting partnered with clinicians, support clinical caregivers using reliable health technology. More information will be sent via the chat you have in the bottom of your screen. I am Fabiola Martinez, Biomedical Engineering and Management Professor at Universidad Autónoma Metropolitana in Mexico City, and together with Mr. Shen Kung, aka Alan, will moderate today's session. We are joined by Professor Nicholas Palikrakis, Professor Dan Clark, and Dr. Michael Cheng. Next slide, please. The agenda for this webinar is as follows. After a brief introduction to the main topic, quality and safety, our panelists will present Q&As through medical device vigilance, innovation, regulation, and frameworks. Then we will have some minutes for questions from the audience. For this, you can use the Q&A section in the bottom of your screen. Next. Quality and safety in health technology is an essential topic in healthcare, since they have an intense influence on the outcomes of the several procedures on the patients and also on the staff performance. So we made use of the definitions of health technology, clinical engineering, and health technology regulation. In particular, this last concept emphasizes the importance of guaranteeing patient safety through medical devices. We also have strong support on very valuable resources as the Clinical Engineering Handbook, with chapters dealing with topics such as regulation and patient and medical device safety. Next slide. In addition to the Clinical Engineering Handbook, other sources represent an overview of the aspects related to quality and safety in health technologies, from papers presented in international forums to publications with high impact in the clinical and HTA fields. Next. The functions of clinical engineers and health technology managers in quality and safety are governed by the principles of leadership that are presented. These principles need to be learned by all practitioners to advance their careers. Next. Academy and government can work together to achieve satisfactory levels of quality and safety in health institutions. The case I present is a 15-year collaboration where the university and a national health institute join forces to offer solutions to the various aspects of safety and quality that arise in the hospital environment. The way to develop this collaboration was through co-directed projects where the strengths of both parties were used. The university contributing with the professor's experience in research and methodological development, and the Institute contributing with the Biomedical Engineering Department expertise and domain of the clinical field. In this case, a professor at the Universidad Autónoma Metropolitana and the heads of the Biomedical Engineering Department of the National Institute of Respiratory Diseases developed undergraduate and graduate projects where the students proposed and implemented solutions to health technology-associated problems. The experience gained in applying quality and safety methods and tools used in other fields, allowing to deepen and generate knowledge that can be extrapolated to other health facilities. The sample of projects listed show the various aspects that can be addressed from the perspective of quality and safety. This scheme has been very positive for both parties, since all involved obtain benefits. Most importantly, high-value elements are provided for the safety of the patient and the medical staff, as well for the quality of the functions in the institution. Now I welcome Alan. Please go ahead.
Thank you, Fabiola. Next slide, please. Hi, everyone. Welcome to attend today's webinar at this special time during the COVID-19 pandemic. Among all the routine tasks of hospital clinical engineering service, quality and safety is a cornerstone and an antenna topic, which is the main theme of today's webinar. I'm Zheng Kun, Director of Logistics Service Department, which includes clinical engineering and facility engineering at the Children's Hospital of Zhejiang University School of Medicine in Hangzhou, China. My team is doing some projects aiming at improving quality and safety of technology for patient care. For example, as the slide shows, as the winner of IFMB CED Best Manuscript Award 2019, the paper addressed alarm management project in my facility. Based on the survey and analysis of medical equipment alarm situation in ICUs at the hospital, several measures to reduce non-actionable alarms and address alarm fatigue are implemented. This is even more important and needed in fighting the COVID-19. Next slide, please. Khalil, next slide. Thank you. Today, we will have 3 subject matter experts to illustrate the best of quality and safety approaches and describe the most significant leadership principles necessary to achieve these results. Professor Nicholas Palikakis, Institute of Biomedical Technology, University of Patras, Greece. His topic is a QS, medical device vigilance system developed for Greece and the EU. Professor Dan Clark, head of CE service, co-director CHT, Nottingham University Hospital, NHS, UK. His topic will be a QS approach through a national CHT innovation center. Dr. Michael Chen, global patient safety advocate, Ottawa, Canada. He will talk a global QS holistic approach through understanding medical device regulations and systems management framework. And dear attendees, please check the QR box and submit questions online while watching the presentations. The speakers will address them later in the QA session. Thanks. Now, let's welcome Professor Palikakis. Please, Professor Palikakis, your time.
Good morning, good evening to everybody. First of all, I would like to thank Tom and Kaliroy and the whole Clinical Engineering Division for this invitation and the extraordinary work that they are doing all this period. Dear Fabiola and Alan, thank you very much for your kind introduction. The topic today is quality and safety, and in my presentation, I will focus on the European Medical Device Vigilance System. Next, please. I think that we will all agree that patient safety is a very critical component of all healthcare systems. Quality, in fact, in healthcare begins with patient safety. Next. If we have a first look on the medical device life cycle, after the initial idea and the innovation that will be more elaborated by Dan, then we have the clinical trials where patient safety or volunteer safety and user safety are becoming important. The regulatory approval of the devices, if they are proved to be satisfactory, the clinical trials, and the fact that in order to put a medical device on the market and in Europe to get the CE mark, they have fulfilled the regulatory of the directives and the standards that are imposed for this kind of devices. Then when they come into use, the medical devices are belonging and especially equipment in the area of clinical engineering that are responsible to manage them correctly in order to assure that they can perform according to the manufacturer intended purpose. Vigilance comes in this part of the use of medical devices. And when there is enough evidence, health technology assessment can be then go back and see if all these equipment are really performing as was intended in the beginning and make the cost-effective and cost-efficient part of HTA. Next, please. So there are three pillars that they are dealing with medical device safety, the regulation that puts a lot of emphasis to vigilance, and this is quite strange because regulation in general, it is to regulate the market. And then management, where vigilance really comes into force, and assessment at the end. Next, please. Any adverse event that causes or has potential could cause unexpected or unwanted effects involving patient safety is called adverse event. It is estimated that 10% of hospital admissions are compromised with adverse events or medical errors. However, it is important that most of them are preventable, and therefore we need vigilance in order to avoid repetition of such adverse events in the future. Next, please. I'm not going to describe the legal framework in Europe that contains directives, regulations, European norms, CE mark, and guidelines. But I would like to say that in these regulations, two things are regulated from the beginning: post-market surveillance and medical device vigilance system. And the purpose of medical device vigilance system is to improve the protection and health of patients, users, and other persons by reducing the likelihood of reoccurrence of incidents somewhere else in another time at another place. Next, please. So there are three players that are involved in the European medical device vigilance system: the users, the competent authorities, and the manufacturers. And there are systems that are assuring the flow of information from users to the competent authorities through the user reporting systems that each European member state has to implement in its own territory, the post-marketing surveillance that the users are referring to the manufacturers, any adverse event, and finally the medical device vigilance system that assures the coordination of investigations between competent authorities and manufacturer whenever it is required. The important steps in this system are reporting, which is the basis of any vigilance system. Without reporting, we cannot be aware of the adverse events that happen. It is also the investigation, the decision for investigation, and the implementation of recalls. And there are two important prerequisites for that: the common codification nomenclature system used and an updated and proper medical device inventory. So the establishment of a medical device vigilance system is essential for the creation of a safer environment in healthcare and a precondition for the prevention of adverse events. Next, please. Just to add that a follow-up is also very important, and I think this is the only real missing part in the regulation. Why we need an application coding and nomenclature system of medical devices? We need it in order to be able to have the information required for all adverse incidents as it should be done. Actually, the European Union has funded the existence of GMDN, you all know it, and GMDN was founded and started in the early 2000s after a period of development from the end of 90s to the beginning of year 2000. However, GMDN failed to become a global nomenclature system. And in the new EU regulation voted in 2017, the Commission is engaged to ensure that an international recognized medical device nomenclature will be available free of charge to manufacturers and other natural or legal persons required by this regulation to use that nomenclature. For the moment, it is the Italian system that will replace the GMDN, and now we're in the phase of mapping the Italian nomenclature system with this GMDN system. However, I think that it is very important to have a nomenclature system that will be based on the work that is under development by WHO, that will, in my opinion, will be by far the best solution, since it will guarantee its proper evolution, maintenance, and will be in connection with the ICD-11, the International Classification of Diseases. Why an inventory is important? It's important because otherwise we cannot compare the reports, the vigilance reports, and the call alerts and recalls of medical devices if we don't know really what it is in our hospital. And the reports have the form of what is in the upper right corner of this slide, and FDA reports are quite similar to the UDAMED reports. However, I have at this point to stress that it's quite strange. The policy of European Union is following, that is not giving access to UDAMED apart from the competent authorities and to a certain extent to notified bodies.
Nick, you only have 1 minute left. Thank you.
Okay, then I will move directly to the next slide, and I will try to, next please, Leroy. I will try to give a story that I think is a quite successful case of applying vigilance. This story comes back to the 99, when we had to face the year 2K problem. The Greek Ministry of Health at that time, in 99, assigned to INBIT the responsibility to face this challenge. Databases with potentially vulnerable equipment for year 2K, based on international database of FDA, ECRI, and other sources, was available. However, we realized that national-wide medical device inventory was not available. So we have to go through all Greek hospitals and make a registration of medical devices. we identify then by comparing the two databases about 2,500 items that have been put out of service during the 31st of December 1999, and the result was quite successful. No adverse event has been reported. Next, please. Another story, more recent and relevant, is the MediVipas project that finished in 2016. This project was applying artificial intelligence and data mining algorithms to identify adverse events devices from official sources. This project was quite successful from academic point of view, with publication in scientific journals and presentation in international conferences, but not yet a real working application is available. Next, please. The above work was made possible thanks to the efforts and dedication of a large number of staff and collaborators of INBIT since '91 that it has been created, and most of them are alumni of the European Erasmus Biomedical Engineering postgraduate program that started in '89, just 30 years ago, and we were going to celebrate the 30 years of existence on May 23rd, but COVID changed our plans. We hope that we will be able to do it so in September. And now I think I have 3 more minutes, Tom, to...
Nick, you do not. Time is up, sorry.
So I have to stop?
Yes.
Okay.
Okay, thank you, Professor Clarkis, for telling us the story of Europe medical device vigilance system, and also mentioned the nomenclature issue, the inventory issue, and the Y2K issue. And medical device adverse events reporting and management is very important for patient safety. And also, you mentioned the MediVipas project. And this is indeed a step further to improve the vigilance system to enhance patient safety. Now, let's welcome Professor Clark from UK to deliver his presentation. Please, Professor Clark.
Thank you very much, Alan, and thank you everybody for tuning in this afternoon to listen to these presentations. It's a great pleasure for me to be here today. You know, people sometimes ask me, where do I find the time for all this innovation on top of the busy operational demands of running a department? And I tend to answer as politely and constructively, of course, I hope. But in truth, if people are asking that question, then you've probably got the wrong idea about what innovation is. It is not something that you can just squeeze into your other busy operational day. It is not something you can find ring-fence time to do, you know, 1 hour at the end of the day or whatever. It's not something that you can do after you've finished all your other operational duties. No, innovation is something that you have to be doing all the time. Every operational task that we have gives you an opportunity to improve safety and quality through innovation. Every teaching duty we have gives you an opportunity to improve safety and quality through innovation. Every time you look at a safety notice, an incident investigation, equipment commissioning, or whatever else it is you're doing, there's an opportunity to improve safety and quality through innovation. Next slide, please. So I'm going to look today at how we've developed in Nottingham a system for doing healthcare technology innovation. And I'm going to give you 3 examples, 3 stories, if you like, of what successful innovation looks like, and how we've managed to achieve that here in Nottingham, and what I think is the key thing to making innovation happen in healthcare technology. So essentially, you need 3 components, I believe, for successful innovations. The starting point has to be the patient. If the patient isn't the center of your thinking, then you're probably in the wrong business. They provide the opportunity, the unmet healthcare need for us to solve. Then, of course, you need innovators. Now, innovators can come from anywhere. They can come from academia, they can come from research organizations, they can come from healthcare providers. Indeed, they can come from the patients themselves or the patient's family. Most usually, I guess, they come from the university sector. But like I said, innovators are everywhere. Now, you can have a genuine problem, a genuine unmet healthcare need, and you can have wonderful, clever ideas from your innovators, You can have all the fancy technological solutions you like in the world, but if you don't have a means to produce them, to manufacture them, to distribute it, to deliver it to the patient, well, then you might as well not bother. So the third key element that's often overlooked in innovation is you need to have industry. Now, here in Nottingham, we've brought those three components together to create what we refer to as the Centre for Healthcare Technologies. Let's now take a look at a few little examples of how we brought those three components together to enable successful innovation to improve safety and quality. Next slide, please. So in this first example, the starting point for this opportunity to improve quality and safety was the patient, the diabetic patient who happens to have a foot ulcer. And in this slide, we can see on the left-hand side a picture of the foot ulcer, and then the image next to it was obtained using a hyperspectral imaging system, and it shows the distribution of oxygen across the foot and across the ulcer, which was developed by the innovators at the university. And this is a hugely beneficial system, devised in a combination between the university academic staff and the healthcare staff in the hospital, and it enables us to know an awful lot about what's going on in the physiology and develop treatment plans for our patients. But the equipment we need to do this is rather large, and the patient has to come into the hospital in order to have these taken. What we really wanted was a system that was small, robust, could be taken by the patient into everyday life, and ideally could be worn by the patient all the time. Next slide, please. So enter our industrial partner. In this case, the industrial partner was a small company called Footfalls and Heartbeats, whose normal line of work is developing smart fabrics, materials that have sensors in them for the elite sports industry. However, working with us at the Centre for Healthcare Technology, they helped produce a range of fabrics into which we could apply a whole pile of clever sensors to do measurements. Next slide, please. So we've now developed a pair of socks, and in fact, a whole range of clothing and fabrics into which we can put sensors now to measure all sorts of things. We can measure blood flow, oxygenation, pH, a variety of other physiological parameters, and including, in this example, capillary refill time. So it was by bringing on board industrial know-how to manufacture these products, together with the innovators from the university and the hospital healthcare team, which enabled this to be a successful project. Next slide, please. So in this second example of improving safety and quality through innovation, we call this SurePulse. And the starting point for this example, as you can see here, is a very small premature baby in need of resuscitation. Now, the key parameter, if you need to resuscitate a small baby like this, is their heart rate. And you can't use.
It's been asked that you slow down a little bit for the non-English speakers, but you're doing great.
Sorry, Tom, I do tend to blunder on, don't I? So the key parameter when you're trying to resuscitate a small baby like this is their heart rate. And the difficulty we have is that you can't use pulse oximeters because they don't work, and you can't use ECGs because the sensors, the electrodes don't attach, and they're too bulky anyway. So actually what we rely upon here is the clinician using a stethoscope. It's very old tech, but it works. But the problem with using a stethoscope is, in order to be able to measure the heart rate, everybody has to stop for 10 seconds while the clinician listens. And in those 10 seconds, nobody is helping the baby, nobody is resuscitating the baby. And it's a very critical and a very urgent time. And you lose 10 seconds every time the clinician needs to measure the heart rate using a stethoscope. Next slide, please. Now, as it happened, completely independent to this, we were working with the university and an industrial partner trying to measure the heart rate of miners and other industrial workers who were working in hazardous environments. And we were fitting sensors into their helmets, into their hard hats, in order to measure their well-being and protect the workers. Now, this was just a small project. It was just a couple of PhD students working on this project, and they were giving a lunchtime seminar one day, as is our practice, and quite by chance, one of our consultant neonatologists just happened to be in the room. He saw this safety work that we were doing with the hard hats and the helmets, and he said to us afterwards, is there any chance that you could put that technology into a soft cap that I place on my little babies? Next slide, please. And so the project was formed. Of course, the answer was yes, we could find a way to get this technology into the soft cap on top that the little babies can wear. And the project ended up being called SurePulse, because it measures the heart rate using a simple photoplasmographic detector. You can see it's a very simple device, but it fits into the little woolly hats that the babies wear, and it gives us a real-time measure of the heart rate. So now if there is a crisis and the baby has an arrest, you don't have to stop resuscitating the baby because you can see what its heart rate is all the time. Next slide, please. For this third example of improving quality and safety, this one starts inside the ambulance, where we often have to transport some of our sickest patients. And again, in this case, I'm concentrating on premature babies, on neonates, who are being transferred from remote hospitals into our central referral centre. Now, we treat these babies very roughly when we do this. We put them in a plastic box. We attach the plastic box to a metal trolley, along with a whole pile of other equipment. We bolt that trolley into a tin frame of an ambulance, which is really just a transit van. And then we drive it along busy roads between the hospitals. In fact, we put the baby in a place where the noise and vibration they feel actually exceeds the occupational limits for lorry drivers in the UK. So surely we thought we can do better than that for our babies. Next slide, please. In this project, we turned again to the university sector for the innovators, and we went to the mechanical engineers who happened to be doing a lot of work on transport systems. Now, these boys and girls like to crash things. So they like to crash cars and car seats, and here's an example of them doing that with a child seat. And they're very strong on measuring what happens to people in cars and transports. Next slide, please. And in fact, they've gone further than that. They've even gone to the trouble of crashing planes in the Nevada desert to measure what happens to people in a plane crash. But this time, we set them the challenge to work on something much more important, we felt, and that challenge was to work with our hospital teams and bring in industrial partners to design a safer, quieter, smoother transport system for our tiny wee babies. Next slide, please. So in this project then, we worked with the clinical teams, we worked with academics from the university, and we worked with industrial partners, in this case, Parade, who made transport trolleys, and Jaguar Land Rover, who of course make cars, amongst other things, and have a lot of expertise in making smooth cars and good suspension. And we brought them all together to make a system which was stronger, safer, with reduced noise and reduced vibration. These are just 3 examples of where bringing healthcare, bringing innovators and bringing industry together leads to improvements through innovation to safety and quality in healthcare. And right now is a good time to mention the way that ideas come about, because in the current COVID crisis, we're seeing lots of examples of people using medical equipment in off-label, in strange ways. And we've started a couple of projects already, bringing our clinicians and our industry partners together to look at what happens with CPAP, what happens with different types of CPAP, the amount of oxygen that we use in high and low flow situations, and whether we can save patients from having to go into intensive care using that. There are opportunities to develop these projects all the time. But successful projects don't happen all by themselves. Like everything else we do that's successful, they require good leadership. So I now just want to take a couple of minutes to look at 3 of the examples of clinical engineering leadership principles that have been so much a part of the work that we've done. Next slide, please. So the first principle, not surprisingly, I've picked up on today is around developing an innovation culture. Now, we have a saying in the UK, which is that from tiny acorns to mighty oak trees grow. And I thought, since I was talking about mighty oak trees, and I come from Nottingham in the UK, I couldn't help but mention one of the most famous oak trees in the world, which is the major oak, which is what that picture is there, which a few hundred years ago was the hideout place for Robin Hood and his merry men. And actually, when I was a little child, I also hid in that tree, though these days it's a protected place and you're not allowed to go anywhere near it. Anyway, what's my point? My point is that successful projects, big projects, important projects, all start with very small ideas. And clinical engineers and people working in our field are really well placed. We're working all day, every day in the healthcare environment. We're coming into contact with little ideas all the time about how we might be able to improve safety and quality. And the trick to developing an innovative culture is to listen to those ideas, wherever they come from, respect them, pay attention to them. Of course, they won't all come off. They won't all become great projects, But if the senior team in clinical engineering is known to be responsive and always listening to these good ideas, then people will keep presenting them to us. And from one of these tiny acorns, a mighty oak in the form of a wonderful project will occur. And as I said, at a time of COVID, there are lots of these examples presenting themselves to us all the time at the moment. Next slide, please. Is it my system that stopped? Next slide, please. Thank you. So the second leadership principle I wanted to focus on was teamwork, and actually in particular on shared goals. Throughout my 30-something year career in this area, it's been apparent to me that there's often mistrust and misunderstanding between those three essential components: healthcare, academia, and industry. People are suspicious of each other's motives sometimes. Healthcare often feel that industry just wants to make money. Academics often think healthcare is too slow, too stuck in the past, won't change. Industry often thinks academics are too abstract, too theoretical, and find it difficult to work with healthcare industry and so on. But despite there being very different approaches from these three areas, and you need to recognize and respect those different approaches, all three parties deep down want the same thing. We all want improvements in safety and quality in healthcare. The trick to successful innovation and successful working generally is to recognize that in order to be successful, you've got to understand shared goals and you've got to manage the different approaches that you'll find. If you work with these different people and they come at it in different ways, you'll be surprised how adaptable they and you can be in the pursuit of great project ideas. Next slide, please. And the third leadership principle I wanted to talk about was this one about being humble. And when I talk about being humble, really what I mean for me is at least recognizing your place in innovation and recognizing your own strengths and weaknesses, as well as indeed the strengths and weaknesses of other parties. More than anything else, the single lesson I think I've learned from working in these innovative projects is that the key to success is actually the role that clinical engineers play. We're at the heart of healthcare. We're on site, we're with patients, we're with clinicians daily. We understand healthcare technology like no one else. But we're engineers, we're scientists. We understand what innovation means. We're used to working with academics, we're used to working in universities. We can speak that language. Some of us are actually academics as well. And on top of that, every day of our working lives, we're dependent on industry to do our jobs. We buy and use commercial equipment all the time. We speak to industrial colleagues all the time about service and support. We understand the needs and drivers of industry. So uniquely, I believe, we have a foot in all three camps. We're naturally at the heart of all three core elements required for innovation. And therefore, we're uniquely placed to be the central driving cog that makes the whole innovation machine work. Next slide, please. So finally, I'm just going to finish with one slide, which is the team of people that actually make the Centre for Healthcare Technology work. There's myself, of course, but then I've got a co-director who leads for research and a co-director who leads for training and industrial liaison. And then the bottom row are the people who do the real work, Tanya, Sarah, and Adatu, who organised the programme for the Centre for Healthcare Technology. Next slide, please. And I think that's everything I wanted to say this afternoon. So thank you very much.
Thank you, Professor Clark. Very inspiring presentation. And the three successful medical device innovation examples are evident for enhancing patient care quality and safety. And the role of leadership principles playing in the innovation is also very well addressed. Excellent. Now, let's welcome Dr. Chen to deliver his speech today. Dr. Chen, please. Michael Chen?
Yes.
Your time.
Right here, right here. Good. Right. Well, thank you, Fabiola and Alan. Hello, everyone. Today, I'm going to introduce two chapters published in Clinical Engineering Handbook, presenting two frameworks of medical device safety and optimal outcomes. Since these frameworks are highly condensed, I shall only outline their key messages and significance. And hopefully in future sessions, co-authors of these chapters will present more details. In short, Chapter 53 presents an essential 3 steps to ensure patient safety. And from these same 3 steps based on safety, we expand it into a 3-stage framework that includes optimal outcomes. These are frameworks of systems within systems. They have a long history of development since 1984, and these are outlined in Chapter 49's appendix. Next slide, please. Next slide, please. Now, the next slide is, I think, is a list of the 2 landmark documents from which these 2 chapters are evolved. Have you got the second slide that lists those 2 landmark documents? Yeah, that's it here. Now, the 2 landmark documents are the World Health Organization Medical Device Regulation and the World Bank on Medical Device Policies. And these are all available on their websites, and you can Google them for your own information. Next slide, please. Now we come right into these 3 essential steps to ensure patient safety. Step 1, the majority of the public focus on regulatory approval. This follows the tradition of drugs. However, drugs have a much greater safety margin when cleared by the regulator because of the rigorous testing before release to the market. It is unrealistic to expect devices to be regulated like drugs. Medical devices regulations are based on risk classification, and lower risk devices are not tested at all. Drugs depend mainly on active ingredients for outcomes. A device depends on how it is used for outcomes. So the user interface between a device and its outcome requires 2 additional steps by the user to ensure patient safety. Now, here in step 2, it is important to note that step 1 the regulation does not cover the unique environmental and human factors that will affect a particular user. So the user must understand the specifications of the device, of the marketed device, and decide whether the marketed product is still safe in the user's contextual situation. For example, a device may no longer be safe to use in extreme temperature conditions or humidity conditions. A device designed for use in calm patient wards may not be safe if used in emergency or operating rooms. Some devices may require teamwork with extensive training. In medical device incidents, adverse events, as mentioned, presented by Nicholas, the term use error is very important in medical devices. It is not anyone's fault resulting in medical error, but a system fault resulting from incompatible environmental and human factors for medical devices. So use context assessment is an essential second step before you adopt certain medical devices. Now moving on to step 3 in utilization stage. Again, we should realize that medical device regulation mandates only manufacturers to preserve device quality in packaging and even transportation up to product delivery to the users. After delivery, however, it is the user who must take up the responsibility to preserve the quality of devices in use, to practice safe use, and to monitor device performance. Now, we see these are all basic duties of clinical engineering day in and day out. So, based on global medical device regulatory principles, this 3 steps framework is a powerful demonstration of the essential work of clinical engineering in healthcare facilities to ensure device quality and patient safety. Regulators or policymakers cannot deny this demonstration. I have presented this to the FDA, CDR, the medical device department, and also the Health Canada. None of them denied this, and they agree with this. So clinical engineers can use this framework to gain high-level military health recognition.
Excuse me, Dr. Chen, you may need to hurry up.
Sorry?
Speed up. We are behind the schedule, so you may need to hurry up.
Oh,
You're halfway through your allotted time, Michael. Thank you.
Sure, right. Good. Now, so with these same 3 steps, we then, by including management elements, next slide, please. So we include other management elements. The 3-step safety scheme expanded to become a 3-stage generalized system management framework. And this condensed holistic framework can be linked to all relevant activities in the commercial lifespan of medical device utilization. If we look closely, this management framework is actually a graphic implementation of the World Health Assembly Resolution 60.29. It can serve, the framework can serve as educational framework for all stakeholders to recognize the complex role of clinical engineering. And in this step 3, very important is the good management practice, which if you see into the detail of this chapter, the 10 essential elements are based on quality management system concepts, the ISO 9000. They consist of essential elements that can be applied, adapted to different situations from a single workshop into a hospital's complete engineering department. This good management practice is taught in Pretoria University in South Africa and used by a South Korean group to help low-resource countries managing medical devices. Now, in terms of, you see that, the next slide, please. This framework actually link the HDR, HTA, and HDM you often hear to some compact frameworks to ensure patient safety and optimal outcome. This framework has been recognized by a recent very high-level European healthcare policy journal. Is the Improving Healthcare Quality in Europe. And again, the reference is given to you. You can Google that for reference. Now, let me leave the leadership principle for you. Just go to the last slide. Proposal for CED. Please move on to the last slide. Last slide, please.
1 minute left, Dr. Chen.
Okay, I just like to point out that during the first Global Clinical Engineering Summit in 2015, there were the conclusion of two needs from clinical engineers. One is the need for great recognition from the Ministry of Health level. Can you move to the next slide? The last slide? The last one. Move on. Yeah, that's it. So that's the first one is the need for great CE, HDM recognition by the Ministry of Health level. And then the second one is to improve the education of both initial and throughout the career. Now, here I would suggest to the clinical engineering committee group that these two frameworks will address these two needs. And I would propose that the community go through this presentation and also the chapters which given in detail, and then bring in common suggestions to CED to collect, and then we could answer those in future sessions, as well that we eventually can collaboratively improve this framework and use them to help ourselves and colleagues in low-resource countries worldwide. This is my proposal, and we can work on the detail how this can work. Thank you.
Thank you, Dr. Chen. 3 essential steps to ensure patient safety, namely product safety assessment, use context assessment, environment and human factors, and safe use and management. And furthermore, it expands to become a 3-stage generalized system management framework with patient safety first principle is very well summarized and highlighted. And now we are going to the QA session. Here is a question. Do you think it is necessary to adapt the clinical evaluation methods for new medical devices according to their level of risks? Anyone want to comment, answer this question? Dr. Chen, would you please answer this question?
I'm sorry. Can you repeat the question again? I was for some
Do you think it is necessary to adapt the clinical evaluation methods for new medical devices according to their different levels of risk?
Yes, it is definitely, because medical device has such a variety in forms and in risk levels, to put it this way. Some are invasive, some are not, and it's a physical valuation that it requires this risk class classification in regulation, because otherwise it's an impossible task. Drugs is very simple. They are mostly chemicals, and then they can be easily subject to double-blind randomized study. this is not the situation in devices. So to expect the devices to be regulated like drugs is not realistic.
Okay, thank you. And the second question is how can we define the high risk medical devices?
Well, these are all
medical devices
classified by the Global Harmonization Task Force and the IFMDR criteria. They're all in the guidance document. All these classification devices are defined. Invasive, for example, invasiveness, and also other criteria. You have to go back into the guidance document, and these are clearly defined.
Okay.
I
Thank
may
you.
add that the medical device directives and regulations have a clear definition of high-risk medical devices. They are classified class 3, and this is according to the classification rules that are taking into account the invasiveness of the devices and the risk for the patient. So the high-risk medical devices are simply class 3 according to the medical device regulation in Europe. And it is similar for FDA.
Yes.
Okay.
It's
Okay,
a
thank you.
classification.
We have a question from Professor Carrier from Brazil, and he asked, is there any development regarding the comfort for patients in ventilators that stay more than 10 days on bed?
Shall I pick that one up? Yeah, I'm aware of a few things that I'm personally involved with. The first one would be dynamic mattresses. There are a lot of available dynamic mattresses on the market, and we're currently doing a study to evaluate the relative efficacy of these devices for critical care patients. So that would include COVID patients staying in ITU for 10 days or longer, but it would also include a whole range of other patients who have a long period of time of immobility. And there's a whole suite of devices available out there, from ripple devices, from anti-shear devices, from pressure alternating devices, from air fluidized devices. They all come with different claims from the manufacturers, and we're currently doing a study to try and it's a product evaluation study to try and see if there's any particular differences in which ones we're going to adopt locally in Nottingham. The second thing I'm aware of that we're very active in at the moment, it takes me back to the second example, I think, in my presentation, and that was we've developed a range of materials that can sense pressure and oxygenation and fluid flow, and we're putting them on tubes, CT tubes, which we're using in ventilated patients to look at the damage that the tubing does to the throat, the airways, when it seals, to enable mechanical ventilation. So we're doing a study there about blood flow and how we can increase blood flow, which, although the patient won't notice the comfort at the time, they sure as hell will when they come out of intensive care and the intubation is over. And then the third element that we're looking at is not really comfort per se, but we've defaulted around the world in treating COVID patients in ITU and elsewhere, but particularly in ITU, with rotating and proning patients. It just seems to have been in the established practice now, prone patients during in intensive care COVID patients. And yet there doesn't seem to be any evidence to support that in terms of documented literature. So we're looking at a study to see whether, I mean, we know intuitively that proning patients get different parts of the lungs active again, but we're looking to see whether there's any evidence to support that. And so a small study has been started. Unfortunately, no, it's good news. We've got too few patients at the moment to complete that study, which is good. It means we haven't got that many COVID patients in our intensive care anymore, but it does mean we're not going to be able to complete that study for a little while yet.
Okay, because the limited time, we have the last two questions. The first, also a quick answer. The first one is, should a new medical device be evaluated on its own or integrated with the end user and its environment?
Oh, most definitely the second part of that. Medical devices, I think Michael said it, somebody said it today, medical devices The efficacy of a medical device is very much dependent on how it is used and its application, where it's used. You can get different levels of efficacy for a device that's used in the home environment, exactly the same device that's used in a professional healthcare establishment. You can get different that if the staff aren't trained. If it's a complex device, training becomes more important, in fact, than some of the engineering features. So absolutely, a device should be evaluated in the context with which it's going to be used.
I fully agree as well, and this question also is very valid now that due to the COVID-19, a lot of regulations are questioned, and I think that regulations is now clear that are not fitting exactly worldwide requirements, but are more oriented to the countries that they develop them. So the context and the environment and the user is very critical for the safety and also the performance of the device. And this is the big difference we have in drugs and devices.
Okay, thank you. Tom, the last question is for you. You have a question for
Nicholas, you know, we know how hard it is to set up vigilance systems that work in our countries. What were some of the leadership principles that you had to use to do that would help all of us?
If you will give me, I will give just an example on
Right.
evidence-based decisions. When we apply evidence-based as leaders, we are avoiding imposing things. We are convincing. And this is a very critical issue. I think that by evidence-based decisions, we can choose the right track to tackle a problem. If I have 1 more minute, I could give you a recent example. In Greece, as you may know, we went extremely well up to now with COVID-19. Very limited cases, small number of human losses, healthcare system didn't reach even 50% of its capacity and had the time to be restructured and better organized. What is behind these very positive results that save thousands of lives? In fact, is that Greeks followed the instructions. How this was possible? Greeks are not by nature, very obedient. I think that the way the measures have been presented was not, you should do this because I know better than everybody else. It was altogether, we must follow strict measures like careful cleaning hands, keeping distancing, stay at home, etc., because there is a strong evidence that these measures are effective. At the same time, in various questions, why not adopt this or that? The answers were based on evidence. Answers like, there is not enough evidence to do this, or there is evidence to do that. Everything said by the leader of the expert advisory group, Professor Sotiris Tsiodras, was evidence-based. And I could say that I don't know him, but I'm grateful to him, not only for the results of the approach on COVID-19 for Greece, but also for the excellent example of evidence-based decisions he gave with such a big success in Greece. So evidence-based decisions are the cornerstone of any leadership principle. Thank you very much, Tom, for giving me the opportunity to say that.
Thank you, Nicholas, for the answer. Now I will give the call to Fabiola to wrap up today's webinar. Fabiola, please.
Thank you. Thank you, Alan. We want to thank the panelists for their valuable participation and for sharing their stories on quality and safety in healthcare. I want to thank Alan for partnering this session with me and to the Clinical Engineering Division for the opportunity to be part of this fantastic initiative. We remind you that next Friday, May 15th, we have the WHO CED COVID-19 critical topic town halls that be focused on pulse oximetry global issues for COVID-19 care. You can register using the link provided in the chat section. Also, the next competency webinar will be on June 10th with the topic Partner with Clinicians, Support Clinical Caregivers Using Reliable Health Technology. Please don't forget to subscribe. Thank you all for joining us. Have a wonderful and safe time. And remember, together we can make it better.
So this concludes today's webinar. See you next time. Bye-bye.
See you.
Bye.
Take care.
Bye, everyone.
Bye, everybody.
Stay safe.